let's talk about, what the fuck are these? Heart failure. What a great way to start a recording. um, so, um, heart failure is a clinical diagnosis. It is, it we can measure it using something called an echo, but for the most part, it's a collection of um, symptoms that creates this really complex syndrome. And the biggest thing is that when we talk about heart failure, the key characteristic is that we either have structural or functional uh, impairment of the ventricles. And really, it all comes down to this idea is that the ventricles are not keeping up with the demand in the body. And so we start to see the ability for the heart to do its job fail, which is essentially what is going on here. So there are a bunch of different terms that you'll hear regarding heart failure. Regular old heart failure. So when we just talk about heart failure, we're talking about the impairment of the ventricles. The other term that you'll probably hear a lot is congestive heart failure. Does anybody know what congestive means medically? Right, edema, fluid accumulation somewhere. So this is where you have the impairment plus edema. So can you have heart failure without having fluid collection? 100%. 100%. The biggest thing here is that we're talking about fluid overload. So there's too much fluid accumulating, usually in the interstitial space. You get peripheral edema, but you also might get like you see evidence of JVD, stuff like that. Other terms that you're probably going to hear are things like HFpEF, which is heart failure with preserved ejection fraction. Essentially, what this is talking about is that your ejection fraction is the amount of blood that is there a value that we consider to be volume overload? There is technically. We could talk about it a little bit, but it's mostly based on like uh clinical diagnosis. Like you stare at it and you say, oh yeah, they're overloaded, or you're like 10 pounds above baseline sort of thing. But there isn't a set value. Yeah, for the most part, you just take a look at it. So when we talk about the ejection fraction, what we're talking about is the stroke volume, which is well, actually, here's a question for you guys that you should know. What is stroke volume? When we talk about stroke volume, what are we talking about? It's a really, really big term. Here we're talking about the amount of blood. Yeah, exact. Amount of blood pumped by the ventricle. So if you have normal function, then we expect to see the normal amount of stroke volume, right? If we start to see evidence of heart failure, right, meaning that the ventricles are not functioning as well, we start to see HFpEF. HFpEF is specifically when your ejection fraction is higher than 50%. So let's say that your normal ejection fraction is, I don't know, 100 milliliters, something like that. Some nice whole number, 100 mils. If when you're 20, we can measure it, it's 100 mils, but by the time that you're 60, it's only 60 mils. Then we can divide that and say, all right, 60 divided by 100, you have 60% ejection fraction. That means that you are HFpEF, right? There's a impairment, not enough blood is being pumped out, but we still have a good enough amount of function. The biggest thing about HFpEF is that we still have good left ventricular filling and pressure. So in other words, in HFpEF, you still can accommodate for hemodynamic changes, right? So someone who has HFpEF is still able to, run up some stairs or, maybe go for a little jog, something like that. They're able to do some exercise, but definitely not as much as they used to. Compare this with something like HFrEF, which is where your ejection fraction is less than 50%. And this is where we start to see our classical symptoms of heart failure. We can divide our symptoms of heart failure into general symptoms and specific symptoms. So what are some general symptoms that people are going to feel when they have heart failure? Yes, big. Fatigue, tired, lethargic. Yep. What else? What's going to happen to, not necessarily dizzy. Dizzy is more related to blood pressure and peripheral vasodilation. Think what's going to happen to the heart. So as the stroke volume goes down, so we have cardiac output equals heart rate times stroke volume. So just like you guys said, we're going to get a tachyarrhythmia. Or sorry, not arrhythmia, tachycardia. Can this precipitate into a tachyarrhythmia? Yes, but it's not a requirement. Cardiac remodeling, 100%, which we talked about previously when we went through the RAS system. We, at the end of stages, we start to see cachexia, which is wasting syndrome. Essentially what it is just as the heart is decreasing function, there's less oxygen going to all the organs. So you start to see, just a general dying of the body overall. Okay. When we talk about specific symptoms of heart failure, what we're really interested in is left-sided heart failure versus right-sided heart failure. For you guys right now, we're going to treat both of them the same, but it's important to understand why either one is going to be causing different issues. Yes, it's basically general organ failure, except it's not a quick organ failure like we normally talk about with like chronic kidney disease or chronic liver disease eventually leading to organ death. This is like slow years someone's just kind of wasting away as their organs start to die slowly. When we talk about left-sided heart failure, just going to erase this for a second. Remember that when we talk about the heart, I just want to make sure I'm getting this correct. Yep. So we have our right atria, our right ventricle, then our left atria and our left ventricle. When we talk about where blood is coming from, so we have deoxygenated blood coming from the tissue, right? Which then goes into the right ventricle, which gets pumped to where? Where is this deoxygenated blood going to? The lung, right? Once it goes through the lung, it comes back into the atria, where it goes down into the ventricle, where it is then sent up through the aorta to the rest of the body, right? So if you have a left-sided heart failure, what we are talking about is a decrease in the left ventricle function. What this means is where is fluid going to back up? Is fluid going to back up in the general periphery, or is fluid going to back up in the lung? In the lung, right? Where is, so we have the left ventricle, it's no longer working, right? It has decreased function, which means that we're going to back up into the atria, which is going to back up into the lung. So what happens in left-sided heart failure is that you get fluid in the lung. And this is where we get the hallmark symptoms of left-sided heart failure, which is pulmonary congestion. And remember what we talked about earlier, congestion means fluid. So we're going to have symptoms of having fluid building up in our lungs. And what's that really going to sound like? Or what's someone going to present as? What would, yeah, dyspnea, right? You'd have trouble breathing. This means that we're going to hear kind of a kind of a dry cough, just constantly like, right? Because they feel like there's something in their lung, but they can't get it out. You're also going to have shortness of breath, right? Because your lung isn't functioning as well. The other thing that can happen here is that you get pulmonary edema, right? Fluid building up in the lung. And then if you were to listen to someone's lungs, what you would hear is bilateral rales. So an auscultation, which is just listening to their lung with a stethoscope, you'd hear that would be how they sound. right? Because they're not breathing as well. So if you have a patient who's coming in with dyspnea, you have left-sided heart failure. Compare this with right-sided heart failure, where is fluid backing up if we have a dysfunction in the right ventricle? So we have right ventricular dysfunction. Right. So we get dysfunction in the right ventricle, which backs up into the right atria, which backs up into the tissue. So this means that we're going to end up getting fluid in the periphery. So what kind of edema should we expect from, yes, big old ankles, right? We get peripheral edema. So peripheral edema starts at the lowest point in the body because it's pulled down by gravity. So it will start in your ankles, giving you big old swollen cankles. Then it goes to your legs. Then eventually it goes to your trunk area. And then if it gets bad enough, it can go to the chest and then eventually your lungs and everything, your heart. It's really, really, really bad. Why is edema so bad? Right? I think we can all agree that having fluid accumulating around the lungs is bad, but why would having fluid around just your like like your ankles be bad? Right. So in the beginning, there's little danger of death. But as you start to move up towards the trunk, that's where we start to get organ congestion, right? So as the fluid keeps accumulating and accumulating, then what ends up happening is that you put pressure on the liver and then you get jaundice, right? One of the first organs to be congested is the liver. Um, the other sort of kind of symptoms you'll see come out of it all has to do with the organ congestion is things like nausea, uh, decreased appetite, um, GI upset. Does this make sense? Anybody have questions about left-sided versus right-sided? So can someone have both? Yes, you can totally have both. Generally, people are going to have one or the other, and then as things get worse and worse and worse, we start to um, see one get much much worse than the other. Um, real quick, just other terms that you might see is something like HEF, IMP, F, which just basically means that you were below 50% at one point, then we did something, and now you're above 50%. You improved, right? So don't get confused by these terms. So this can also mean that you increased by 10 points from baseline. So if you were at 20% and you went to 30%, we would consider you imp F, right? Still not great, but it is what it is. All right. So real quick, just to go over what he was talking about, this whole thing about wet, dry, that whole business. What we can say about heart failure is that we can have conditions where we are wet or dry, right? Essentially, what this is talking about is uh, congestion, right? Do you have symptoms of congestion, right? And we can see that no matter which ventricle is causing the failure, you have some sort of accumulation of fluid depending on where it is, right? If it's left sided, it's in your lung. If it's right sided, it's in your body. So if you are wet, then we need to move you to dry, right? And so the way that we're going to do this is with diuretics, right? Best way to get excess fluid out of the body is with diuretics. So we want everyone to be in a dry state. We don't want them to be congested. The other measure that we look at is we have warm versus cold. And what this is talking about is, I'm not going to be able to write at an angle. Oh God, I'm not going to be able to write at an angle. This is talking about perfusion, right? So in this case, we're not necessarily talking about like vasoconstriction. We're more talking about pressure, right? So if the ventricles are so dysfunctive that you are cold, meaning that you have no blood going to the periphery, then this can quickly become no blood going to your organs. And so there are kind of different there are different ways that we can deal with this issue. Sometimes it might be vasodilation, although not very often. Sometimes it's inotropy, but uh, that is for next semester. We'll talk about that. And then obviously, if you're wet and you're cold, then we have to do a combination, right? We do diuretics to get you to become dry, and we do inotropy to get your heart moving. Does that kind of explain that a little bit? Okay. All right. Let's talk about classifying, and then we will move on. Does he want you to know the ACC AHA class, or does he want you to know the, I think it's like the Los Angeles Heart Association or something? ACC. Is it, does he want you to know like ABCD, or does he want you to know like 1, 2, 3, 4? Wants you to know the 4 pillars. It's probably ABCD, which is the ACC. Oh, okay. Yeah, I get it. Okay. When we look at classifying the heart failure, again, what we have to look at is not only the symptoms of heart failure, but also the risk factors with it. And that's what really sets apart the new ACC, American College of Cardiology, American Heart Association stages from the previous, I think it's the New York Heart Association class system. Where the previous classes were all about, what is their current function, the stages are more about prevention as well. So we have our first stage, which is A, and this is a risk stage. So if you can be classified as at risk of heart failure if you have risk factors like hypertension, especially unmanaged hypertension, clinical ASCVD, or a high ASCVD risk, diabetes, and then any kind of family history of cardiomyopathy. So if your family is known to have heart failure, then we would put you at high risk of this sort of stuff. The second stage here is pre-heart failure. So what we're talking about is that you have evidence of at least one of these things. So either you have some sort of structural heart disease, right? So this would be a reduced ejection fraction, or it could be, we take imaging of the heart and we see ventricular hypertrophy, which, if you remember, hypertrophy is just the muscle tissue has grown, become thicker. You have increased filling pressure, which again, this would be taken by using a Swan-Ganz probe, I believe. And then you have risk factors plus increased BNP or increased troponins. And we'll talk about those in a second. What's important to note is that in class A, you're asymptomatic. Why are you asymptomatic in stage A, I should say? Why is stage A asymptomatic? Don't overthink it. Yeah, you don't have heart failure yet, right? You can't have symptoms of heart failure if you don't have any symptoms. Same thing with stage B, right? What we are seeing here is that you have evidence that something is going on, but it hasn't actually precipitated into symptoms yet, right? So at this stage, we can still prevent it. By the time we get to C, this is where we start to see the signs and symptoms of heart failure. Stage D is where we have advanced heart failure. And really the difference is that the signs, the symptoms disrupt daily life. So, or the other one is frequent hospitalizations. So maybe they can't walk up, 3 stairs without getting winded, or maybe they can't sleep at night because their fluids are accumulating, their lungs are accumulating so much fluid they can't sleep, right? It's at stage C that we finally start to see symptoms, right? And they get worse in stage D. Any questions about that? You will need to stage your patients. You will need to know where they go. All right. When we talk about heart failure, let's put this in perspective. When we talked about hypertension treatment earlier, what was first line for hypertension? What are you immediately going to put someone on for hypertension? Thiazide diuretic. What was the alternative to the thiazide? Someone said it. Loop. What if they needed something else? What was the next line? ACE. And if they couldn't do ACE, you'd do an ARB. And then third line drugs, beta blocker, calcium channel blocker. Usually, specifically, what kind of calcium channel blocker? What are we going to be using? DHPs, right? Difedipine, amlodipine. Why? Why do we want DHPs and not diltiazem or verapamil? Where are DHPs working? Right. No heart effects, right? So these are working as vasodilation, whereas if we picked verapamil or diltiazem, that's going to have a direct effect on the heart, right? Which we may not want. So this is where non-DHPs, verapamil, diltiazem, very good in arrhythmia. But when we talk about hypertension, not very good because we'd rather just affect the blood vessels. All right. When we talk about heart failure, in stage A, what drugs are we, or how are we going to treat someone in stage A? So someone who is at risk of heart failure. Not nothing. Not just watching. Not an Arnie. Two things. Lifestyle modifications. Optimize risk factor treatment. Right? So if they have diabetes, treat their diabetes. If they have hypertension, treat their hypertension. Right? So if when we're in stage A, we're trying to prevent the progression as much as possible. So optimizing someone's therapy is always the first step in heart failure. It's always the first step in really any complex disease. Once we get to stage B, which again, we're starting to see signs that heart failure is developing, the biggest thing that we're trying to do is prevent symptoms, right? So really what this is trying to say is have no edema, no congestion, whether that's in the lung or if it's in the uh, no congestion, whether it's in the lung or the periphery. So what are we going to give someone to prevent edema? And think about that, right? Prevent edema. They don't have edema yet. So diuretics are really good for when fluid is there, but we don't have, remember, stage B, they don't have any symptoms, right? So do they actually have any fluid? No. So here, we're going to use a beta blocker. Why are we going to use a beta blocker? What is the purpose of a beta blocker here? Right. To prevent or undo cardiac structural damage. Uh, yeah. The other thing too is that this decreases the stress on the heart, right? So what's happening here is that the uh, beta blocker is being used because the heart is trying to work too hard. And so in order to compensate, it's remodeling itself. So the beta blocker's goal here is to prevent and try to undo some of that remodeling that went on. Once we get to stage C, do we have edema? Yes. Yes, we do, right? Because by stage C, we actually have signs and symptoms of heart failure, which means that we have fluid accumulation. So at this stage, we need to treat the edema, which is where we get our 4 pillars, right? So what are our 4 pillars? First pillar, beta blockers, right? That's going to be an obvious choice if you haven't started it already. Then diuretics, get that fluid out. What's your first choice? We'll get to Arnie in a second. I promise. I promise we will get to Arnie. I don't know what his pillars are, but I'm explaining to you like what we do. I don't know. I'm just telling you how I treat my patients. But what's our first line in patients with heart failure? Arnie is not uh, a diuretic, but loop diuretics first, right? Why are we choosing loop diuretics first in heart failure patients and thiazides second? Right. Loop works better. They work much, 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 much better. So we're going to start with a loop diuretic because unlike hypertension, if we don't choose the maximum diuretic, you're not going to die from hypertension. You will die from pulmonary edema, right? If we don't get that fluid out of your lung, you will die. The last stage here is RAS. The next stage is RAS modulators. First, as you guys love to point out, is an ARNI, sacubitril valsartan. Second is ACE. And then obviously, if you can't do an ACE, you do an ARB. I don't know why well, I do know why, because ARNIs have really, really good outcomes. The problem is that that nobody can get ARNI. like Entresto is just really hard to get. But it does have really, really, really good outcomes compared. And then our last section here is our SGLT2 inhibitors. All right. By the time that you're getting to stage C, you are picking one from each category. So you're picking a beta blocker, you're picking a diuretic, you're picking a RAS modulator, and you're picking an SGLT2. When you're in stage D, we start to see some of the other potential add-ons. So this could be things like the mineralocorticoids, or sorry, the potassium-sparing diuretics. This could be things like vasodilators, specifically hydralazine or isorsabide. We might see things like digoxin, right, which is for rhythm control. And then finally, we would see things like the funny channel inhibitor. Which, does anybody remember the funny channel inhibitor? Ivabradine. So, stage C, you're picking one from each category, right? And then if you're still not solving the issue, then you pick one of the add-ons. That is heart failure in a nutshell for you, right? Does that make sense? Does anybody have questions about that? Does this help simplify heart failure for you, like we did with hypertension? Okay. All right. That's really my goal, right? I'm not going to go through each individual drug, mostly because we've already talked about all these drugs, right? We've already talked about beta blockers, diuretics, RAS in terms of Thera. So by now you should have a good idea of, what are uh, the the adverse effects for a beta blocker. What are the adverse effects for a loop diuretic or an ACE inhibitor? That sort of stuff. Big thing is watch your potassium, watch your heart rate, and watch your blood pressure. That's really what it is. Couple of things to note about heart failure, just so that way I can kind of round this off. In heart failure, the bad guy here is drugs that increase the congestion in heart failure. So when we talk about what drugs do we not want to give, we are talking about drugs that are going to either decrease the function of the heart, or they're going to decrease the increase fluid retention. That's really the big issue here. So these drugs are going to do one of those two things. All right. First, first class of drugs, the non-dihydropyridines. So things like verapamil, diltiazem. Why do we not want to give verapamil or diltiazem? We talked about it a little bit earlier. Right. We're going to decrease the function of the heart. They're more potent than beta blockers, right? So what that's going to do is that is going to cause the ventricles to stop working as much, right? We have too much heart degradation. How about NSAIDs? So things like ibuprofen, naproxen, ketorolac. These guys are going to affect the kidney, which is going to increase fluid retention. So they help with keeping sodium in the body. How about the certain antidepressants? What do we want to be careful about with antidepressants? Essentially here is that these can they don't necessarily decrease the function of the heart, but they more of have a hypotensive effect, specifically the tricyclic amines. So think like amitriptyline, nortriptyline, those sorts of guys, mirtazapine. Only certain ones. Uh, what kind of stuff there? Just some things to kind of bear in mind. Any questions about heart failure? All right, sweet. All right. What was the other one on this exam? Stroke, right? Like crazy. Stroke, glaucoma, pharmacogenomics. Ah, okay. Would you guys rather do stroke or pharmacogenomics? Didn't have genomics yet. Okay. Um, we'll quickly go over. We can probably. Oh, we're ahead of schedule. Yeah, we can get both done. Yeah, we're way ahead. Stroke isn't that bad because we've already talked about anticoagulants. All right. When we talk about stroke, right? When so a stroke is a neurologic condition. And it comes from a blockage in cerebral perfusion. So, in other words, there's some sort of clot that happens in the brain that ends up causing the ability for blood to flow to decrease. There are two different kinds of stroke. You can have a hemorrhagic stroke, which means that there is usually some sort of tear in the blood vessel, which causes blood to leak out of the blood vessels and into the brain space. Can be very, 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 very bad. It's only maybe like 15% of all cases. It's really, really, really low. The other, way more common, is ischemic stroke, which this is related to a clot. So just really quickly, how are we going to treat an ischemic stroke? What kinds of drugs are we going to use? Anti-clot or pro-clot? Anti, right? The reason is because in ischemic stroke, you have some sort of clot causing a blockage. When we talk about hemorrhagic stroke, it's not a one-to-one parallel, but we treat it by being pro-clot, right? We want to get the clot in there. We just have to be careful, right? But we don't necessarily treat it that way. But I just want to surgery, yes, surgery, huge part of it as well. But the idea is that we want to stop it from bleeding, right? That's the big thing. All right. I'm trying to think of what. All right. Going back to what we talked about last exam, what topic did we talk about last exam that is very, very similar to what's going on here? What did we talk about last exam? What was the overall category? Right. So, the ASCVD. Well, they would be both kind of under ASCVD. I think it would be. What is it classified under? Eh, I guess they're two different categories. We'll talk about them separately, though. Let me think real quick. Yeah, we want to talk about this in terms of PAD. All right. I just want to make sure that I'm pulling the same parallels like we did just now. All right. So previously, when we talked about peripheral artery disease, VTE, DVT, all those sorts of different things. What were the four drugs that we had to have in order to treat either I kind of want to all combine it together just so that way we're not confusing ourselves. What were the four drugs that we needed? Right? So we needed an antiplatelet, which could be aspirin, or if you couldn't do aspirin, we would go on to, or it could be either or clopidogrel. So now I remember how I was teaching this. We have two categories. We have symptom treatment, which the first kind was antiplatelet, right? We need to get rid of the clot, which was aspirin or clopidogrel. What was the other kinds of symptoms that we had to treat? What was the other thing that we had to do? Vasodilate, right? Vasodilation, because that's going to treat our symptoms of, in coronary artery symptoms, it's going to relieve that chest pain. DVT, it's going to, help open things up. And then our second category of drugs was all about prevention. So what was our first kind of preventative? Was the statins, right? These drugs are all going to decrease the likelihood for a clot to form again. And then what was our last category? What was the last thing that you need to choose? Yeah. In the case of coronary artery disease, beta blockers, definitely, right? Which I'm trying to figure out a good way to previous anti-clot. Beta blockers, something to control the rate of the heart, right? That's essentially the biggest thing. I just want to have like a good way of categorizing what's going on. When we talk about stroke, we're going to have the exact same principles. The problem is that we are looking at immediate treatment and then preventative treatment after the fact, right? So it's like when we were talking about DVT, where we need to initiate pretty robust antiplatelet therapy, but then we're going to follow it up with prevention. So for stroke, when we talk about acute treatment, all right, so someone comes in, they currently are in the middle of having a stroke. First steps first is symptom treatment. We need to use a pretty advanced and pretty fast-acting antiplatelet, which in this case is going to be the alteplase, right? Or the tissue plasminogen activator. The other one that I think, did he tell you about, does she tell you about tenecteplase? That's the other one that can get used. No? Okay. Then just TPA. Okay. They're the same thing. Alteplase is the recombinant version of of uh, TPA. Sorry, I'm looking at multiple things. In order to get TPA, we have to have certain requirements. First is no evidence of hemorrhagic stroke. This is going to be based on imaging in the brain, right? So they're going to look at the brain, this, this would be the kind of thing where someone came in after a car accident or they had an aneurysm and it ruptured, some sort of thing like that. But the biggest thing here is that why do we have to rule out hemorrhagic stroke before we give alteplase or give TPA? Yeah, if we give, it's hard to reverse alteplase once we gave it. So if we in hemorrhagic stroke, we're just going to make them bleed and bleed and bleed until they die, essentially. If it is less than 3 hours since the stroke began, we can have all adult patients who are at risk of like a disabling stroke, right? So they have a pretty clear uh, um, idea of stroke is happening. After about 4.5 hours, we have to use MRI to see if the clot is still there. What's the danger of using alteplase 4.5 hours after the stroke occurred, right? So let's say that someone wakes up in the morning, they roll over to their wife, and their wife says, "Oh my God, your face is drooping. You had a stroke in the middle of the night." The reason is because if it's after this long amount of time, it's unlikely that the the thrum the it's unlikely that the thrombus is going to create another stroke. Or in other words, it's already dislodged and now it's somewhere else in the body, but we don't need to use as high of a therapy as um, alteplase. We can use other management. So the reason why we don't use it after 4.5 hours is because alteplase would be overkill in this case, right? It's already been hours since this issue has happened. We don't need to necessarily um, use it. Did she talk about like complications of TPA, like airway collapse and all that? No? Okay, probably not. Oh, she gave a bunch of exclusion criteria. Yeah. It all essentially boils down to if they're currently bleeding or if they had surgery recently, don't give them, the drug, that sort of stuff. Um, all right. So we okay, great. Great. So we treated their acute stroke. Now we have to go on to chronic treatment, which is really the same thing as saying prevention, right? We killed the current stroke. Now we have to make sure that we stop the next one from happening. And the biggest thing here is that we're again looking at expectations. Whoops. All right. First steps first, antiplatelet therapy. And this is going to go to our same sort of abilities, right? We're going to choose aspirin or clopidogrel or dual antiplatelet therapy, right? So if aspirin alone doesn't work, we give clopidogrel as well. Or if you're allergic to aspirin, then we give clopidogrel only. Uh, the next portion here is we're going to treat modifiable risk. And these are all the same things that we talked about before, right? Statins, beta blockers, and things like lifestyle modifications. So decreasing weight, decreasing alcohol consumption, treating sleep apnea. Does anybody know why sleep apnea can result in? It's because it puts pressure on the heart, can cause heart failure. Not really not good for the heart, sleep apnea. Yes, if you are allergic to aspirin, you go directly to clopidogrel. That sort of thing. Oh, smoking. Smoking is a huge one. That includes cigarettes, vaping, or marijuana. They shouldn't do any of that. And so again, I'm not going to really dive into this too much because we've talked about statins, we talked about hypertension, right? That's really what this is. Oh, no, it really goes down here. Hypertension, diabetes, right? All your risk factors, that sort of stuff. So I don't feel like I necessarily need to. I think it's more important to just understand, like, all right, what is the pathway that you have to choose for your different people. So if they are currently having a stroke, you give them alteplase. If they are post-stroke or at risk for stroke, then you do antiplatelet, and then you do your statin, beta blocker, and your lifestyle modification. You could even throw in a vasodilator if you wanted. So it's essentially the same 4 steps. It really is. It doesn't get any more intense than that. Does it make sense? Any questions about that? Yeah. ACE inhibitor. They probably have hypertension. Give them an ACE inhibitor. They most likely, unless if they're really young. But all right. If we have no questions about that stuff, let's go into pharmacogenomics, which I think will be kind of an interesting way to end the night. All right. when we talk about pharmacogenomics, the idea here is that we can use gene testing to determine what the optimal therapy is, right? So we're not talking about modifying someone's body to have a different gene. We are just talking about why does someone have a suboptimal response versus another person has toxicity. And that really comes down to analyzing what kind of genes do they currently have. So let's take a look at an example. If we look at just the CYP3A4 enzyme, if we know that we can have people who have normal function, we can have people who are fast metabolizers, I think, sorry, should be using the right vocabulary. Rapid, very rapid, slow, and very slow. Right? We have a whole spectrum of some people. It could be that 80% of people are normal function for CYP3A4. Then we have 5% of people are rapid, 5% of people are slow, and then 2.5% are very slow, 2.5% are very rapid. So let's say that we have a 3A4 substrate, right? If someone is a very slow metabolizer of this drug, are they going to have are they really going to be metabolizing the drug that much? If you're a very slow metabolizer, are you going to metabolize this drug? Not at all. So you have little metabolism. And maybe this is where we start to see things like toxicity. If you are a slow metabolizer, then we have some metabolism. And where I would, can take this drug and have, exactly the response I'm thinking, maybe this person has increased side effects. Someone who's normal would have the normal optimal response. Whereas someone who is rapid is going to have uh, increased metabolism, which maybe is a suboptimal response, right? They got some ability to have the drug do its thing, right? Maybe it's an antidepressant. They had some anti-depression activity versus someone who's very, very rapid is going to have almost no response because the drug is being cleared so quickly. And this is really the backbone of pharmacogenomics is if I was to pick you and look at your liver panel and say, okay, you are a rapid metabolizer of 3A4. How does that factor into what drugs we're going to choose? That's really what pharmacogenomics is all about. Uh, I think it's a spit test now. You can get it done online. I've my treatment resistant like depression, treatment resistant anxiety patients, I usually have them do it because they uh they tend to they tend to have some sort of interesting phenotype going on. All right. So let's look at one panel. CYP2C19. Actually, maybe we'll do 2D6. When we look at the different kinds of alleles that are present, what we can have is hundreds and hundreds and hundreds of different alleles, right? And we can classify these based on what kind of function that person would have. Now, what's important to note is that you're going to have you have two chromosomes. So you're going to have one pair of alleles, a gene, from your mother. You're going to have one pair of alleles from your father. And so we can get an idea of what kind of metabolizer you're going to be based on what kind of genetics you had. So let's say that Tom is a 2d6 star 2 star 2. What kind of function would he have? According to our chart, what kind of function would he have? Normal, right? We can see that 2 is right here in the normal category. So he has normal function, right? So what kind of metabolizer is he? Completely normal. Well, Sally is 2d6 star 2 star 3. So what kind of alleles does she have according to our chart? She has normal function and no function. So overall, what would be her kind of metabolism? Is she making no enzymes? Nope. Of the enzymes she has, they're completely normal. And what we find is that just because she has one copy of the allele doesn't end up mattering, right? So she would still be normal functioning, right? She doesn't have decreased function because in order to have decreased function, she'd need to have one of those alleles. So her enzymes are working at the correct level. What about if we have Sarah, who is star 10, star 17? She's decreased function. What if instead someone was star 2, star 17? What would that be? Normal and decrease, overall becoming normal. Right? Because same sort of situation up here. Just because you have one allele that's not as good, it doesn't mean that the other allele is some mixture of the both, right? We take the highest functioning allele, right? What would be increased function? If we had something like star 1 star 2xn, that would be an increased function. Now, where it starts to get a little bit funky is where you start to, decrease function, increase function, right? Do you need to memorize these different alleles? No. She will tell you on the exam what they do, right? Um, there's I think 300 and something alleles for 2d6. So you don't have to memorize these. You do need to know how to work with them, right? So let's take a look at um, an example. So let's say that our patient is on the drug nortriptyline. Nortriptyline, does anybody know what nortriptyline is used for? Antidepressant. So in terms of the optimal response, what should someone have as the optimal response to nortriptyline? Yeah, less depression. If you had a uh, uh, well, let's go into our question. So our person, Autumn, is uh, star 41 star 55. What kind of function does she have? Decreased function, which means what kind of metabolism is she going to have? Is she likely to be slow or is she going to be very slow? Very slow, right? This is where I wanted to separate out the idea of what the chart is telling us versus what we see, right? And so this is the difference between genotyping and phenotyping. So, in terms of her functionality, she's a very, very, very slow metabolizer. So, is Autumn going to have increased or decreased levels of nortriptyline in her body? Very, very, very high levels of nortriptyline, which means that she's going to have toxic levels, right? Or in other words, she's going to have really, really bad side effects. So, what would be the best choice for her? If I wanted to treat her depression, exactly. So, in terms of choices I could make, I could lower the dose of nortriptyline, or what's the other possibility? What's the other thing that I could do? Right. A non 2d6 drug. And that's essentially what pharmacogenomics is all about. I see this all the time, especially with my psych patients, right? Someone says that this drug isn't working. Well, the reason why it's not working is because you metabolize it so quickly. So let's take a look at another example. Let's say that who do we have in here? Let's say Pierre is 3A4 fast metabolizer, a 2C9 slow metabolizer, and a 1A2 normal metabolizer. I want to pick a drug that will treat his depression. Actually, I want to pick a drug that will. How do I want to put this? Well, let's look at each drug independently, and we'll talk about that. So, first drug that he is on is let's say he's on methadone, which is a 1A2 substrate. What do we expect to be changes in his levels compared to someone else? Would he have increased, decreased, or normal levels? He'd have normal levels of methadone. What I will tell you is that no, we're good. All right. Torvastatin. What is going to happen to his levels of atorvastatin? Right. This is a 3A4 substrate. And so we're going to have fast metabolism, which means that we're going to have decreased levels. More metabolism means less overall. So what do we expect to happen with his LDL levels? Do they increase? Are we causing an increase, or do we just not affect them? No effect, right? Remember, just because we metabolize a drug doesn't mean we suddenly cause the increase again. Right. Yeah, this shit again. What would happen to his risk of stroke? No effect again, right? Having decreasing the level is basically the same thing as having no atorvastatin, right? So does having no atorvastatin suddenly make someone at risk of having a stroke? Not at all, right? But if we wanted to talk about his, well, that's really what it is, right? What would happen if he took fluconazole? Which is a 3A4. Oops, sorry. Let's say it's a 2C9 substrate. It's really not, but it's also a 3A4 inhibitor. So we'd have increased levels of fluconazole. And then what would be the other effect? we'd end up raising levels of atorvastatin. So kind of interesting, right? And this is really what pharmacogenomics, the backbone of pharmacogenomics is all about, right? Is that if I have a drug that is oh, inhibitor. That's my bad. IN. If I have a drug that is that has we know is strongly metabolized by one enzyme, then we wouldn't want to necessarily use that in someone who has that poor of a metabolite. Yes, we'd start to, because we're raising the levels of atorvastatin, we'd start to see some effect on LDL and a decrease in stroke. Yep, yep. Where we really care about pharmacogenomics is talking about population-based pharmacogenomics. For example, one of the I'm gonna find, for example, when we talk about populations, we can look at what kind of pharmacogenomics we end up seeing. For example, in there is a gene called HLA-B B15 star O2. If someone has the HLA B15 star O2, which is a gene, right? This is a gene. Then when they take certain drugs like carbamazepine or lamotrigine, they're at increased risk of SJS. In fact, it's almost guaranteed. Maybe not. It's huge ratio. So for whatever reason, the people who have this gene, if they take carbamazepine or if they take lamotrigine, are much more likely to get super bad rashes that could potentially kill them. What we find is that the HLA-B 15 star 15 star O2 is increased in Han Chinese people. So if you have a patient who has seizures and you know that they may be Han Chinese descendant, should you test them for this gene? Yeah, 100%. If you have a Black patient, do you have to test them for this gene? Not necessarily. So this is the interesting side of pharmacogenomics, is that we can look at how population-based pharmacogenomics can inform good practice of what's it called? Of drug choice. There's another really, really good example, but I just can't find it. No, I can't find it. For this exam, what for this portion specifically, what do you really have to know about pharmacogenomics is really just about this idea of this middle part here, right? If you have a substrate and you know what kind of metabolizer they are, what's going to happen to the levels, right? This whole idea about no effect, decrease, increased, I don't think is going to be important for the exam, but it is going to you are going to get questions about, all right, you have the genotyping of the person, what is going to end up happening? What she will give you is a list of genes, right? And the drugs that are associated with them that have established guidelines depending on someone's genetics. So, for example, if someone is a slow metabolizer of clopidogrel, that means that they're going to be at an increased likelihood of bleeding, right? So if you're a slow metabolizer of clopidogrel, of 2C19, clopidogrel is not a good choice, right? We'd choose something else. Same thing with, warfarin for 2C9, codeine for 2D6, all that sort of stuff. She'll tell you specifically what she wants you to know for the exam and what examples to be aware of, but really, honestly, it doesn't get more basic than this. This is really what she wants you to know. That sort of thing. Any questions about that? Does this kind of sort of make sense? I'm looking back at my notes and I just didn't keep very good notes back then, so I'm not entirely sure. But all right, cool. Well, we're gonna wrap up a little bit early. Tomorrow we will go into either medchem or pharmacology, whichever one. Probably do medchem just to get it out of the way. Let me know if there's any topics from Thera you want me to review as we come up to the exam. I'll post some stuff, see different stuff that I can find, and then we'll be all good. Oh, yes. He came out of his cage. He's on my chair. So this is Bactrim. Bactrim's a good little boy. I can pick him up like this.
Dave, stop the screen share so we can see him.
Oh.
And stop recording.
Oh.